let's go to our last case scenario. This is a little bit of a negotiation. I'm going to talk about it a little bit first before we go ahead. So this simulated patient task assessing. You have communication with patient safety, knowledge, and colleagues. You do not have information gathering. I omitted it on purpose, so please do not take history. Just going to waste your time. You're the ST5 in antenatal clinic, so you know what you are, sorry, who you are, where you are. Your next patient is Jessica Taylor, 31 years old, so you know the name of the patient, the age. Gravida 2 para 1. She had a previous emergency cesarean section at 39 or 4 weeks due to fetal distress, and it was done at 6 centimeters dilation. She's currently 37 weeks, no antenatal complications. She has a BMI of 24. She has insignificant medical and surgical history, so no medical problems, no surgical procedures. These can be relevant, so that's why I put it there, and no drug allergies. She has been referred to the Birth Options Clinic at 32 weeks. So those who don't know, it's either called Birth Options or Birth Choices Clinic, where at some point antenatal, usually around from 28 weeks onwards until 32 weeks, they will be seeing the clinic and counseled regarding a VBAC versus elective repeat cesarean section. They don't make a choice then, but it's just a counseling clinic. Well, they would know the benefits and risks of each of these two, given a leaflet. They think about it until they come to their clinic appointment to make up their mind and for you to finalize their delivery plan at around 36, 37 weeks. So this patient was already referred there. She's gone through that counseling. She's expecting to meet the consultant today as she's asking for a home delivery. Okay, so you know she's asking for a home delivery. Attached are her antenatal ultrasound scans. Her blood pressure, we come to the scans in a bit. Her blood pressure measured by the midwife today in clinic, normal, pulse rate normal. Her urine was dipped, so that's done routinely in each visit, normal urine dip. Okay, let's go to her scan. So you have her dating scan, her first trimester screening, her anatomy scan, and her 36-week scan. She was not on serial growth scans because there was no indication. If she had a medical problem, if she had a previous IUR baby, if she was a smoker, if her BMI was high, you know, all of these reasons, then she would be on serial growth scan. If not, then just 20 weeks and then the last scan at 36 weeks. So here, you know she's 37 weeks. She's already gone past the dating scan, the trimester screening test, and the anatomy scan, and also her scan at 36 weeks. They're here for you to go through them so you can counsel this patient properly, just to know if there was any problems antenatally, because I'm omitting information gathering. So anatomy scan findings, you just look at the bottom, single live fetus with no abnormalities. You don't have to go into detail, it will just waste your time in the 2 minutes. And then the last scan at 36 weeks is the most important one. You're looking for the growth and any, what is it called, the placenta localization. That's the most important thing you're looking for because she's a previous scar. So placenta is posterior high, commenced single live fetus, original-like, phallic presentation, like is normal, posterior fundal placenta normal in size and morphology, and biometry is keeping with acceptable growth. So it's a normal scan. So here you know she has an uncomplicated pregnancy until now. The only problem here is the previous cesarean section. Yes, she can go for a VBAC, but that's not the problem. The problem is she wants to go for a VBAC at home, which is not safe. So this will take us to dealing with high-risk women requesting home birth. Okay. So I took this slide from one of the videos that I usually do in my preparatory course to prepare for sessions. There were much more details regarding this, but this was regarding home birth and requests. But this was the most important slide that summarizes everything. So I just took it from there. So when you're dealing with such patients, no matter what risk factors they have, if she's a VBAC wanting to deliver at home, a breech baby wanting to deliver at home, a very high BMI baby with, I don't know, IUGR baby, and she wants to deliver at home, any risk factor, okay? There's a certain approach. It's not really recommended to start like a normal case scenario at the beginning. You just need to shuffle things around a little bit. So basic principles that you need to bear in mind and cover them during such cases is a certain fears and anxieties. Know from her, why does she want to deliver at home? What is the problem with the hospital that is making her not want to come to the hospital? Does she have an issue? Does she have a previous bad experience? Or does she just want to deliver at home because she wants to and has no problem with the hospital? Okay. Encourage and answer the patient's questions, because here it's a negotiation, give and take. Whenever you mention something, ask her, what does she think? What's her opinion now? Every now and then. It's just not, do you have any questions so far? This is not negotiation. It's not like a normal case. Deliver information in varied quantities, gauging understanding. In between, sorry, that was chopped off. So that means chunk and check understanding. Don't give her all the information at one time. Identify the patient's wishes. That would be at the beginning when you ascertain the fears and anxiety, and also towards the end. After your thorough counseling, see what she thinks. Document the plan as agreed with the patient. You have to tell them, I'm going to document everything. Involve the consultant, not always. If at the end of your counseling she agrees and says, okay, I'm going to deliver in the hospital because, she got convinced with what you said, you do not need to involve the consultant. What's the consultant going to do? Just going to document for a be back in the hospital. Okay? You involve the consultant if she still resists and says, no, I want to deliver at home. In that case, the consultant has to see her to counsel her again. And despite that, at the end, if she wants to deliver at home, despite all the counseling and good and clear documentation regarding the discussion and the risks that may happen, she can deliver at home and she will be supported in that. You can't just leave her like that with her community midwife. There would be arrangements with the head of community midwives to know that there's a high risk patient that's going to deliver at home. And once her community midwife goes to her and she's in labor, she will notify the hospital, the labor ward, and who's the midwife in charge, and in turn the consultant and the registrar who are covering labor ward for that night or day, that high risk patient is starting to labor and she's going to be with her. So just that the labor ward would be on standby in case that patient is rushed in urgently to the hospital, either because of fetal distress or scar. The most important thing you'll be worried about is scar rupture. Okay, they would be ready. All right, and an ambulance would be ready just to bring her in quickly. So you can see at the end they are supported, just not because their decision is right, their decision is absolutely wrong, but because patient's choices are respected. She wants that, she can have it. But again, we want to ensure that it's done as safely as possible. At the end, you can't guarantee if she ruptures, that she wouldn't lose the baby. Even if they're rushed to the hospital with an ambulance, she may still lose the baby. She may even lose her life, depending on how much blood she loses. Okay? So understand all of these when you're counseling such patients. So when I'm going to start here, I'm not going to start right away by saying, hi, my name is Wafa, I'm a doctor here. May I confirm your name and age, please? What would you like me to call you? Please call me Wafa. So I understand that you're 37 weeks now. You had a previous cesarean section as an emergency, and you came in because you want a home birth. I'm not going to confirm it like that. I'm going to have an open approach for any patient who's coming requesting, even if she is, for example, severe PMS or severe endometriosis, she's young, within her 20s, and she wants a hysterectomy and bilateral salpingoprectomy. Same approach as well. Okay. Again, if there's a patient with severe preeclampsia, she came into the maternity assessment unit or day assessment unit, and she's counseled for admission and she refuses, and then you're asked to go and talk to her. Again, the same approach because she's refusing, okay, management or against medical advice. So here when I start off, hello, my name is Wafa, I'm one of the doctors here. Are you Jessica Taylor? Yes. Can I just confirm your age, please? Is it okay if I call you Jessica? Yes, that's fine. Please call me Wafa. So Jessica, how can I help you today? That's all after I confirm introduce myself, confirm that that's the right patient here in front of me, I'm just going to ask her, how can I help you? I'll let her tell her story and I'll be listening. Okay? Let her mention as much as she wants, active listening. You always have a lay examiner there. A lay examiner is someone who is, they're not in the medical field. They don't really understand if your management is right or wrong. All they care about and marking you on is the way you're dealing with such patients. They can be in breaking bad news, they can be in negotiation stations, dealing with teenagers or young teenagers, dealing with domestic violence as well. Okay. So after I ask her, how can I help you? And she tells me her story and her request for a home bath. And then I'm going to tell her, okay, that's fine, Jessica. Every woman, I just like you to understand, I just like you to know that every woman has the right to choose when and how she would like to give birth. Okay, because it's her choice at the end. The reason why you were sent here again today is just that because with a previous cesarean scar on your womb, it's not safe to deliver at home because of certain risks, and all we care about is your safety and your baby's safety. Okay. Would you mind me asking, why do you want to deliver? Why would you prefer home delivery against hospital delivery? So it's all, and I'm not mentioning anything knowledge here. I'm just trying to check why is she requesting that? If she tells me just because she, like now, my answer would depend on her answer or her problem. If she just wants to deliver at home because she wants to experience that and she doesn't have any issue with hospitals, then I'll talk to her about that. Okay, Jessica, home birth is, we do understand, I'll tell her we do understand why women want to deliver at home because it's a very relaxing environment. You have control over it, you're in the comfort of your own space, you have your loved ones around you as well. And we do you actually support and encourage women who want to deliver at home, but only as long as it's safe for them to do so. When it's not safe, meaning that there's any risk factors like a scar on your womb, that's when we wouldn't usually advise delivering at home and we're advised to deliver at the hospital. Okay, so because she mentioned that she wants home birth, I'm not ignoring her request, but I'm telling her I started my discussion about okay, the good things regarding home birth and that we usually encourage and support women. But then I mentioned why, in her case, we have concerns. So I'm not using words like, no, you're not allowed, or we don't want you to deliver at home, or it's not safe to deliver at home. These can scare her and make her feel that you're judgmental and you're not understanding where she's coming from. So we say we don't advise or we have concerns regarding your safety and your baby's safety if you did labor at home with a scar on your womb. And before mentioning that, I told her clearly that it's her choice to make at the end. All of that, when you cover it at the beginning, before you going into that knowledge part regarding the risk of scar, rupture, death of the baby, hair death as well, and the bleeding, you're trying to show her that, okay, you want to know why she's asking for that. You want to understand from her, communicate with her, negotiate before just giving her the facts of what can happen. And depending on her reason, to try and what can I say? To try and convince her to deliver in the hospital or labor there, it would depend on her answer. So and you try to find a solution for it. So for example, if she says, well, my sister came in last time, she went into labor, very bad experience, midwife, she didn't like the way the midwife dealt with her. She had a traumatic delivery with instruments and then she had to go for a cesarean section. Let's say that was a reason. Then you tell her, well, I'm sorry for what your sister went through. I don't really know the details about what happened exactly. But again, if or what we try to ensure is apart from having a baby safely and you being and the patient or the woman being safe as well, we do care about patients being comfortable in the labor ward. So I'm sorry about what happened to her. Okay. If you're worried about the same thing happening again, I can assure you that we will try to make you feel as comfortable as possible. Nothing would be done without your consent. At any point, if we want to use instruments or we want to take you for a cesarean section, your consent will be taken. Okay, if you don't approve for it, it will not be done. So I'm trying to reach a certain point in the middle without lying to her around her concern. If she tells you, well, last time I came in, I wanted to deliver vaginally, but then I reached 6 centimeters. They took me for a cesarean section. I didn't want to have it. I wish I just didn't come to the hospital last time. Okay, or she can tell you, well, last time it was very crowded, people coming in and out. It was noisy. I couldn't take it. Then he would tell her, then apologize for what she went through and tell her this time round, what we can do, take you on a tour through the labour ward. We have rooms that are quiet, okay? You can choose the room, look at the rooms, and then if you don't want lots of staff coming in, you can just have an assigned midwife, and one of the doctors, the senior doctor, does have to come and see you. So only these people can come in just to check on you and check on baby. We can make the room more comfortable if you want any music of your choice put in, if you want dim lights, if you want aromatherapy, if you want to adopt certain positions that can be adopted when the monitor is continuously connected to your belly, then you can have the freedom of doing all of that. Okay, so your answer depends, like I said, I repeat again, on what the patient says, because I had lots of students during the course who just sticking to talking about the risks of scar rupture and why it's recommended to be in the hospital for continuous CTG and the ways we pick up scar rupture, and it can cause bleeding, endanger her life, and endanger the baby's life, without trying to find a solution for my main issue why I don't want to come to the hospital. Okay? So you work around these 2 points. Number one, around the patient's concern, why she doesn't want to come to the hospital. When you work around that, then you talk about, at some point, you talk about the risk of scar rupture, why recommending the hospital, because continuous CTG, there will be doctors available, a senior skilled midwife available as well. So as soon as we pick up that there's any problem with her or the baby, then we would take it into a cesarean section as soon as possible. Whether if she's at home, it may take time for her to be brought into the hospital, and we can't guarantee that we'll be able to save her life or her baby's life. Okay? I've done a lot of talking now. I think I spilled everything out. Who wants to do this case? Just imagine you're talking to a friend. You have a crazy friend with a previous cesarean section scar. She comes to you, telling you, well, I'm going to deliver at home. I'm not going to the hospital. What are you going to tell her? It's just the same. Okay, anyone? Angie, your hand is clicked. Did you just click it now or was clicked from the beginning? And who's ever going to perform the case, when you're talking, I can put this up so you can see if you're covering those points or not throughout. Okay, Angie, your hand is clicked. I'll unmute you. Just ask you, did you click it to do the case or it was clicked from the beginning? Okay, if someone doesn't want to do it, I will do it, but I would need someone to be the patient, please. And your reason can be is that last time you weren't comfortable with the hospital. It was really noisy, lots of equipment, people coming in and out. and you didn't really want the cesarean section, you felt that you were pressured to have the cesarean section. That would be your reason. Yeah, who wants to be my patient? Come on, anyone can be a patient. It's quite easy being a role of the patient. And at the end, just put yourself in position. If you feel convinced about what I said, it's your choice. Whether you would say yes, okay, you agree, or you would insist and say you would want to still deliver at home. Just choose whatever you feel comfortable with. Anyone? Andrew, can you be my patient then?
Okay, ma'am.
Yeah? All right. Let me put the timer. I'm going to start now. Hello, my name is Wafa. I'm one of the doctors in the clinic today. Can I just confirm your name and age, please?
I am Jessica Taylor. I'm 31 years old.
Is it okay if I call you Jessica?
It's okay, doctor.
Please call me Wafa. So it's nice to meet you today, Jessica. Um,
Okay.
can you tell me in your own words, how can I help you today?
Actually, I am now 9 months pregnant, and I have a baby who has delivered by cesarean section, and it was a terrible experience. But I don't want to give birth by baby at hospital, so my nurse asked me to meet you here.
Okay, so I understand you wanted to have a home birth. Is that right?
Yeah.
Okay. I'm sorry, Jessica, for what has happened before. You told me you didn't have a pleasant experience with your previous labor and delivery. Can you just elaborate more regarding that? What happened exactly?
Actually, it was also a normal pregnancy, and whenever I got pain, uh, I got to the hospital, and there, my baby was not delivered. They give some injections, and later on they said that his baby was not in good condition, and they need to do the emergency cesarean section. And it was so painful after section. There is a lots of pain, and it takes few weeks to recover. So I'm not interested in going to the hospital for delivery.
Okay, I'm sorry, Jessica, for what you have went through, and I apologize on behalf of the hospital for your bad experience. Can I just ask, how's your baby doing at the moment?
She is doing fine.
Okay, all right. And how did you recover after the cesarean section? I understand you said it was quite difficult, but after that, did you have any long-term problems?
No, I'm okay now.
Okay, all right. So, Jessica, I'd just like to tell you that patients have the right, pregnant women have the right to choose when and where they would like to give birth and deliver. And we usually support them in whatever choice they make because at the end, we just want you to be comfortable and we want to ensure that you're safe. Okay. Home birth is we do understand why women would prefer home birth because, it's away from the hospital, none of the noise there, no much of staff going in and out. They feel in control, surrounded by their loved ones as well. And we usually do encourage them and support them with their choice. But that's the case as long as it's safe for them to deliver and labor at home. In your case, Jessica, I'm just quite concerned with you laboring at home just because of the scar on your womb. Okay. I understand that you've been seen in the birth options clinic a couple of weeks ago. Is that right?
Yeah, my GP sent me to the birth options clinic after 8 months.
Okay. And were you taken through, are you aware of the risks that can happen with a vaginal delivery?
Yeah, I am aware of there is a risk of this said that there is a risk of scar rupture out there. My baby is gonna to in trouble, but I'm not comfortable in delivering the hospital as as there are, I mean, they do the cesarean sections.
Okay. So Jessica, just like I mentioned, because of that risk of the scar rupture, that's what's usually concerning us because we do want to pick it up as early as possible just to make sure both you and your baby are safe. Um, like I said, I do understand that you didn't have a pleasant experience in the hospital. What, if you don't mind, what I can offer you is that you can take a look around in our labor ward department where the delivery suite is. We can make sure and write down a birth plan for you that you want to be in a comfortable room. You don't want much interruption or lots of people coming in and out. We can assign for you one midwife and one senior doctor. Doctor has to come in and see you just because of, to assess you in case the midwife suspects any problems with your baby's heart rate or with your heart rate as well. You also have the
Oh,
choice of having two people inside with you in the room. You can dim the lights, have aromatherapy, and make it as comfortable as possible for yourself. And regarding cesarean section, nothing would be done without your approval. Even at some point, if the doctors come in and tell you they're concerned about the baby's heart rate, your approval is required first before going ahead with the cesarean section. What do you think about this?
okay, I will think about it. Okay.
Okay, so think about it, and also I understand that you have been seen in the birth options clinic, but I just want to recap that point of the importance of hospital birth and why we would recommend hospital birth because the scar of your womb with the contractions, there is a chance that it may open up. It's a small chance, but it still may happen. And for us to pick that up, we usually monitor you continuously with straps around your tummy. And babies sometimes can tell us with the continuous reading of the heart rate whether the scar is starting to open up or not. And when it happens, every second or minute counts because the scar opens up, you can bleed internally. It can lead to the loss of your life and your baby's life as well. When you're inside labor ward with us, we will ensure that we act as soon as possible or as quick as possible to ensure your baby's safety and your safety as well. Okay.
Okay. What is the chance of delivery having normal delivery?
And the chance is quite good. It's about 75 out of 100 that you can have a normal vaginal delivery without complications.
Okay, if there is a chance of cesarean section, uh, can I have a normal delivery after that?
Sorry, can you repeat your question?
I mean, can I know the what are the risks of the rupture of the my scar?
So the risk is around 25 out of 100, 25%.
25%. Okay,
Yeah.
this is yeah. Okay, uh, I will think about it. I will discuss with my partner and let you know.
Okay, so that's good. Have a think about it, and whatever, and I'll tell you, whatever decision you make, we will support you. If you agree to come to the hospital, that's fine and well, and we'll ensure you can, with your community midwife, have a birth plan in place. It will be written down in your electronic notes and in your handheld notes. So when you come in labor, everyone in labor ward would be aware about what you would like and what you would not like as well. Okay, and if still, despite you thinking about it, you still want to deliver at home, then we will try to support you as much as we can, although we can't guarantee that we will be able to ensure a good outcome for you and the baby in case a problem happens. So the head of community midwives would be aware about you laboring and delivering at home, and the hospital would be aware as well. In case there's any problem, you would be shifted to the hospital and then we can take care of you there. But again, like I said, we can't guarantee that we can save your baby's life if that happens.
Okay. Okay.
Okay.
Thank you, doctor.
All right. So I'll
Okay.
just document all of our discussion in your notes. All right.
Okay.
And once you make up your mind, just let your midwife know, and then we can just finalize your delivery plan.
Okay, thank
Uh,
you.
Have a minute and 15 seconds. Okay, so Andrew, honest feedback. Did you feel that I was listening to you or not? Because that's what the feedback would
No,
be.
ma'am,
That's
you
exactly
were
the
so
feedback.
at least in my role, I was not a good role player. I was hesitant what to say and what to not to say. This may be a problem for you.
Yeah. So did you feel that I was listening to you? I was addressing your concerns?
Yes, ma'am. It was so nice of you.
Okay. All right. Thank you so much, Andrew, for being the patient. All right. So again, the answer that I mentioned here, I just went along with the flow with what Andrew was telling me. Okay. And every answer that I mentioned was just depending on what she said. So you involve patients with you, and then you covered these points. Asserting fears and anxiety by knowing why she doesn't want to come to the hospital. Inquire in between. Do you measure information? Ask her, what do you think? Okay, what happened? What do you think about what I just said? Chunk and check understanding. At the end, after you finish, identify her wish and then document the plan. And I didn't have to involve the consultant because she did. If she had said, I do want to deliver at home still, then I'll document and tell her to give you a further appointment with the consultant. Okay. All right. Anyone has any questions, please? If you don't know how to type here on the box, you can type it on the Telegram group because I have it open as well. Okay, so we've finished here just because I have a few people here that we're going to start our batch number 24 towards the end of December, and registration is going to open over the next few weeks. So usually what we do is that we do one batch only prior to each exam, just because it's 16 sessions and it's spread out on 2.5 months to 3 months. And I usually ensure that we finish at least a month prior to the exam so candidates can have time to revise and recap and practice. If they want to do mock exams elsewhere or with me, they have the time to do that. Okay, so our courses consisted of 16 sessions, and in those sessions, it's usually we understand that it's a safe and patient-centered care that is required in the exam and also in clinical practice. So we teach and assess the students on their clinical skills, how they apply their knowledge in terms of Part 3 case scenarios, most importantly, their attitude with patients and their attitude with the examiners, because that's marked as well, and their professional values. What we help to achieve is in-depth understanding of how to apply the 5 core clinical domain skills, which are the domains like patient safety, knowledge, information gathering, communication with colleagues, and communication with patients. Okay, these 5 domains, how they are applied in each of the 14 modules. So you know for the modules for the part 2, they're 14, the same for the part 3. One case from each module. In total, you'll have 4 structured discussion, 1 teaching scenario, and 9 patient simulated tasks, which are counseling stations. Now, it's important to know that for each of the 14 modules, the domains are a little bit different. Sometimes there are major differences in how you cover them. Sometimes there's subtle, small differences. Like, for example, patient safety in infertility, the points that you need to cover there are absolutely different from the points that you need to cover in, for example, urogyne module. Okay? In the course, we just focus on the sessions, no much explanation from my side regarding the domain, but rather doing case scenarios during all the sessions. The explanation of each module with the 5 domains, each of the 14 modules, there's 14 separate videos that I did that explain how to apply the 5 domains for each module. Okay, how to gather history, there's any relevant points, how to communicate in terms of communication with colleagues. Are there any certain fixed colleague that you need to involve regarding that module? And that is done prior. You go through these videos prior to each session with a bit of case scenario examples that I do, sometimes explanations of low risk, high risk pregnancies, home birth, a birthing center, delivery in the hospital, explanation of psychosexual problems, how to break bad news, templates. All of that is to you go through them to prepare you for the session. In the session, each candidate, active candidate, will know what cases they're going to do. So I usually give a list of 4 to 5 cases to prepare, and I pick randomly some of these cases. It would be random for you, but for me, I would know which cases beforehand that each of you I have assigned for, and then we give feedback. So you prepare prior to the session with the material and videos, and then you prepare the cases, the list that I give to you from the leaflet and the guideline, the same way we did earlier here today, and then you come and present your case. Okay. We also ensure that you have knowledge of the NHS system in terms of communication within referral pathways, the hierarchy of care, and most importantly, clinical governance. Clinical governance is covered in a lot of counselling stations indirectly, and that's marked as part of patient safety. Sometimes you can have a clear, direct, structured discussion on clinical governance. You will be taught how to apply the NHS core values throughout all the 14 modules, which are respect and maintaining dignity for patients, compassion towards patients, maintaining patient safety and confidentiality, and lastly, teamwork. So each of the 14 modules throughout different case scenarios that I carefully picked that have different approaches, all of these would be applied to that. Okay, and I will teach you how to clearly cover that. And then we'll ensure that you have the knowledge of how to effectively prepare for the exam with numerous tips and tricks under your sleeves. And what I really focus on is the skill of effectively communicating with the simulated patient, because I understand that's a problem for overseas candidates. I've been in your shoes before, so I know how difficult it can be. So I try to explain it in depth and make it as simple as possible. For those working in the UK, the communication aspect is not a big problem, but it's just understanding, how to tick points in the exam. Okay. We also cover a variety of special communication skills. A couple of examples on the different negotiation skills. Diffusing anger, either of an angry patient, a relative, or an angry mother of a young girl. You have a whole session on breaking bad news, how to display or convey empathy and sympathy as well. Okay, and we have hidden agenda like bullying and undermining and domestic violence, in which we cover case scenarios. And then lastly, you'll be accustomed to the art of using professional language with the examiner, appropriately organizing your thoughts, representing your knowledge, using various approaches according to the specific case. Those who know me know that everyone asks me, a lot of people before joining, do you just focus on recalls? I say no, that's not the aim of the course. Recalls, yes, to help you, but then remember, they are recalled. That candidate who went to the exam has written down what they remember from the case and what they understood from the case. Their understanding can be right. Sometimes their understanding of what the case was about may be wrong. You never know. Okay? What's important is to know how to approach cases, how to cover the domains under each of the 14 modules, how to talk to patients, how to convey your answer, how to know when to involve colleagues, how to be safe, okay, and what amount of knowledge is enough for you to give to the patient. All right. So understand. What I focus on is helping you understand rather than memorizing. What I hate the most is when someone asks me, can you give me a ready-made answer? I cannot give you a ready-made answer. I can give you, of course, I do put an answer in which, okay, you covered the case like this after each candidate does his case, and I write it down in slides. But I always repeat, this patient with, let's say, she has PCOS, with her characteristics and her comorbidities, your answer can be absolutely completely different if you have another patient with PCOS but with different characteristics. That's why I always say understand how you're going to cover it, understand the knowledge rather than just memorizing. Because if you memorize just answers without understanding, you will find it really difficult in the exam if you come across a case that you did not practice before. Okay. So the course is all entirely online, 100%. We cover around 100 plus cases, including the cases that I do and the cases covered in the sessions. And then you can access all of these recordings at any time. And we usually keep the recordings for a maximum period of a year in case, you don't want to take the next May exam, you want to take the November, or you don't pass the exam. So prior to each class, you have prep material. Sometimes you have videos and case demonstrations. The classes are only focused on case presentation and giving each candidate detailed feedback and checking their progression throughout each and every session. And I ensure that each active candidate presents at each and every session. Okay. And the number of cases each candidate presents depends on the number of active candidates who are going to present. If the active candidates are 14 candidates, which is the maximum number of seats, because I can't increase it more than that just because of the number of the cases. I can't go on with the session. You would lose concentration if I do a session for 8 hours. Our sessions usually last between 5 to 6 hours, and we cover 7 cases in depth with explanations about that case and surrounding the case. Okay, so you can apply whatever advice I give and feedback I give to other different case scenarios. So you'll have feedback just like the feedback I gave domain wise, and let you know what your mistakes are and what you need to focus on to ensure that you don't repeat it the next time you present. You can access the recording, and then most of the time during the session, I usually advise, please, whoever joins the course, have a small notebook for the course. Because a lot of times during the sessions, I say tips and advices verbally. It's not written down. Whenever a case like we're covering a case and advice comes up on my mind, I usually say it. So ensure that you write it down. We have different types of seats. Okay, we have active, special listener, and we have listener seat. Okay, active seats, there are only 14 seats only. Once they're fully booked, you can either book a special listener or a listener. Active seats, usually they present case and receive feedback during the course on a weekly basis. The benefit of it is encourage you to gradually improve throughout the course period and be 100% confident towards the end, because regularly you'll be receiving feedback and knowing your mistakes. With every candidate has their own weakness. You can find one candidate who presents for the first time, their problem is history taking. The other candidate, they're really perfect in history taking, but their problem is involving colleagues. They usually miss that. Okay, so once I give you that feedback, you write it down, you work on it. That means that's your weak point. You need to focus on it. And then it allows you to track your progress each time you receive feedback. And you have access to the prep material course recording, Telegram group, and direct contact with me if you have any questions. The second type of seat is the special listener seat. Now that's suitable if you would like to receive feedback, but due to work commitments, you're unable to attend most of the live session. Okay. Sometimes those who have an active seats, when they know beforehand the dates and the timings of the course, if they have a problem with a certain date and they can't attend, I try to work around it to ensure at least they present the same number of cases like their other colleagues who have active seats. But then if you feel that 50% of the sessions you would not be able to attend at all, then don't take an active seat, take a special listener seat. You will listen during the session, but after you complete the course, you will present the same number of cases, which are generally I put a whole circuit, which is 14 cases, along with feedback in a one-to-one session with me right away after the course finishes. And then you still have access to the prep material and anything. So at the end of the day, you will be presenting the same cases as active candidates, but at a different time. Sometimes but then the the drawback of a special listener seat is that you won't be able to track your progress throughout those 2.5, 3 months. You will only be able to have that evaluation after the course ends. Okay. What did I want to mention again? And those who take an active seat, but again, they can't really attend some sessions, I usually I write their names down at the end of the course. I ensure that cases, the sessions they wish to present on, they do present cases from that module, but they will be different cases, of course. Okay. The last seat is a listener seat. The listener is just purely a listener. You have access to all the recordings, everything, Telegram group, but you attend the session if you would like, or you can watch the recording. You wouldn't be actively presenting cases, so I wouldn't be able to give you feedback. Some people choose just a listener seat and then later on book a mock exam with me if there's any availability prior to the exam, because I conduct just mock circuits, only a small limited number a month. I start around a month or 3 weeks prior to the exam according to my schedule. And those who get priority are those who are my course candidates. A lot of them would want to do a mock exam. So ideally I do give them priority. If there's extra seats, then I take people from outside, but I don't take a lot of I don't open a lot of seats for mock circuits just because of the time that I have. Okay. All right. I hope all of you have benefited from this. The recording would be available, so please listen to it. Okay. And try to apply it in your preparation. And we do all our videos, we do have it on our YouTube channel. This may take a few days for it to be uploaded because I don't usually, this is going on for 4 hours. I don't like posting recordings as long as 4 hours. I usually divide them, okay, into small bits and then they're uploaded. The same applies for our course sessions. Each session lasts for 5 hours, okay, sometimes 4.5 to 5 hours. We don't post the recording, all of it, 5 hours together. We divide it into cases. So whenever you want to go on to our platform during the course and watch the recording, we'll have the name of the case, 2 or 3 cases together with the recording. It's like an hour maximum or hour and 15 minutes for each recording. Okay. So make sure you watch the YouTube channel. There's lots of videos there. I just want all of you to benefit from them. Lots of examples. Watch them. Although it's been a while, I didn't do videos, but I try as much as I can to have free time and do them. We do have our Facebook group. There's some videos, sometimes I do some posts there and post them whenever I have time. If you have any queries, we have our email where the registration team will look into your queries and questions. If there's anything they can't answer, they forward it to me. spot3circle.rcog@gmail.com, and we have our Telegram group. The links of the Telegram group can be emailed to you after the session if you do not have the links to all of these. Okay, so any questions? No questions? Okay, I know it's been a long session. I was planning only 2 hours, but it went on for 4 hours now. All of you must be really tired. So, okay, I hope that all of you have a nice evening or nice night. And please start preparing from now on. If you're someone new who didn't join any course yet or waiting for our course to start, or you're waiting for any other course that you would like to join, start preparing from now. Go and look at the YouTube videos that I've mentioned regarding preparation. Watch them. You can watch this recording again, okay, to understand. And then you start applying the same to case scenarios. Open any book. The Lisa Joel book, I recommend it, and Professor Condi's Part 3 book. When Professor Condi, start with that chapter that I've written about preparation. Read it really well, and then go and start from the beginning. Lots of nice explanation about the exam from the beginning. So if you're a newbie, understand how the exam is conducted, how the circuit is. That's usually at the beginning of each book. And then you can go into modules and case scenarios. Okay. All right, everyone, I'm going to wish you all a lovely night and say goodbye. by, and I wish you all the best of luck. All right, bye bye.